Hello, my name is Catherine, and I will be your instructor for this course. Throughout this course, we will be learning about how to care for patients on the stroke unit after an acute stroke. Students will learn about what complications to look out for and what nursing interventions to apply. This presentation is intended to give a brief overview of the content in this course. A cerebrovascular accident, CVA, also known as stroke, is the fifth leading cause of death in the United States and leading cause of long-term disability. There are two types of strokes, ischemic and hemorrhagic. Ischemic stroke is when a vessel supplying blood to the brain is obstructed. There are two types of ischemic stroke, embolic, which means the clot traveled to the brain from another part of the body, and thrombotic, which is when the clot forms in the brain vessel due to atherosclerosis. Ischemic strokes account for 87% of all strokes. Hemorrhagic stroke is when there's a brain aneurysm or weakening of the blood vessel that ruptures and bleeds into the surrounding brain, compressing the brain tissue. Hemorrhagic strokes account for 13% of strokes. Post-acute stroke care requires close monitoring of the vital signs. Temperature must be monitored for at least 4 hours for the first 48 hours, and a temperature of greater than 99.5 degrees Fahrenheit or 37.5 degrees Celsius should be notified to the physician, and initiative measures to reduce temperature, such as administering Tylenol, should be initiated. Rectally administer Tylenol if patient does not have the ability to swallow. Blood pressure close monitoring for the first 48 hours and report hypertension or hypotension to the physician. Be cautious in reducing the blood pressure by no more than 20% over the first 24 hours. Hypotension and hypovolemia should be corrected to maintain systemic perfusion levels as to support organ function. Respiratory rate or breathing effort nursing assessment is essential to determine if airway support with oxygen is needed. Oxygen saturation should be maintained above 94%. Only provide oxygen supplementation for those that are hypoxic. Measure blood glucose using finger prick method 4 times a day. The target glucose is between 80 and 130, and a blood glucose level greater than 180 should be treated with insulin. Dysphagia screening should be assessed on admission, and no food, fluids, or oral medications should be given until swallowing ability is determined. Patients that fail the dysphagia screening should follow up with a speech pathologist for swallowing assessment. Here's a list of potential complications after a stroke: hemorrhagic transformation incidents, cerebral edema, evolution of stroke, early reocclusion with clinical worsening, seizure incidents, dysphagia incidents, stroke-associated pneumonia, urinary tract infection or UTI, urinary retention, constipation, gastrointestinal bleeding, post-stroke cognitive impairment incidents, depression, pseudobulbar effect, delirium, impaired mobility, falls and fracture, pressure injury, post-stroke pain, and deep vein thrombosis or DVT. Here are some key nursing assessments. Continue to do neurological assessments and compare it to the patient's baseline. The NIHSS score is a good indicator for severity and change of neurological status. Dysphagia is assessed using a bedside swallow technique. Only attempt if the patient does not have trouble swallowing or staying awake. Sit the patient upright and ask the patient to swallow saliva first, and if they can, then offer a sip of water. If there's absence of coughing or drooling, then that means that they passed the swallow test. Assess for pneumonia by auscultating patient's lungs, signs of respiratory compromise, and monitor for fever of greater than 38 degrees Celsius, and also altered mental status. Monitor for UTI symptoms such as dysuria, urinary urgency, frequency, burning with urination, cloudy urine, and fever. Assess for bladder retention using a bladder scanner. Assess bowel functions such as stool consistency, frequency, timing, and bloody stool. Assess for history of depression using the depression screening tool. Assess for mood swings that may indicate pseudobulbar effect. Assess for limited mobility such as hemiparesis, sensory changes, and post-stroke pain. Use Morse fall scale for all fall risk assessment and Braden scale for risk of pressure injury. Monitor pain scale and give pain medications cautiously. Assess sign and symptoms of DVT such as swelling, pain, tenderness, or redness in one part of the body. This usually occurs in the lower extremities. Recognize the signs of another stroke using the BFAST acronym. B for balance, loss of balance, headache, or dizziness. E for eye, sudden loss of vision in one or both eyes. Face, if the person's face looks uneven. Arm for one side of the arm is weak. Speech for difficulty speaking. And T for time, which is to call cold stroke in a hospital or call 911 if outside the hospital. Nursing interventions. If there are signs of neurological worsening, a cold stroke may be called. The physician should see the patient within 10 minutes if any stroke signs or symptoms appear or worsen from baseline. Then the patient must have a CT scan of the head within 25 minutes from onset of symptoms, and out to place for ischemic stroke within 3 to 4.5 hours if there's no contraindication. Comprehensive assessment for nutrition and hydration by documenting weight from admission and weekly thereafter. If patient fails swallow evaluation consistently, enteral feeding may be started in collaboration with the physician and dietitian. Make sure that the patient is adequately hydrated. Assess oral hygiene and implement oral care at least 3 times a day using chlorhexidine mouth swab. Intensive oral hygiene can reduce risk of stroke-associated pneumonia up to 28%. Administer prophylactic, pharmacological, or mechanical treatment as ordered by the physician. This can include heparin or sequential compression device. Promote early mobilization as well. All stroke patients are considered high risk for falls. Interventions to prevent falls include reminding the patients to use the call bell, use of bed alarm, and collaborate with the physical therapist to provide necessary ambulatory aids. Follow the hospital's skin injury protocol to prevent pressure injuries. This may include turning positioning on a 2-hour schedule, provide air mattresses, avoid excess moisture, and collaborating with the nutritionalist and wound care team. Provide frequent toileting and intermittent catheterization with bladder scan if patients are retaining urine. Administer prophylactic stool softeners as ordered. Avoid infection by using clean or sterile technique accordingly. If the patient has an indwelling urinary catheter, use chlorhexidine wipes to clean the catheter. Provide reorientation for patients that have dementia and provide emotional and psychosocial support. The patient's family may be encouraged to stay at the patient's bedside to promote a sense of security and orientation. The nurse may collaborate with the psychiatrist to provide necessary antidepressants. I hope you enjoyed this presentation, and here are the references. Thank you.